Welcome to this session on mechanical ventilation. My name is Laurent Brochard. I'm working in Toronto, Canada, and I'm pleased to co-chair this session with Domenico Grieco from Rome. And we have a lot of exciting talks around mechanical ventilation, starting with Ary Serpa Neto from Melbourne and a little bit from Sao Paulo, who will discuss of automated ventilation.
Thank you very much, Luca. Good morning, everybody. It's really a pleasure for me to be here. Thank you, Gianluigi, Fabio, and the scientific committee for the invitation. I don't have any specific disclosure related to this presentation, and I just want to start with a quick review of key aspects for an optimal ventilation in the ICU. So, low tidal volumes in ARDS. We all know that we have to do it. Trials from like more than 25 years ago showed some benefit. We have data, we published this some years ago, showing that tidal volume size decreased over the years. However, we don't do it. This is real-world data 15 years after the publication of the ARMA study, and the tidal volume that we use in patients with ARDS, independently of the severity of ARDS, it's basically not low tidal volume. Indeed, it's exactly the same as the tidal volume size that we use in patients without ARDS, 7.8 mL per kilogram of predicted body weight. And why? We have several reasons. Potentially, maybe it takes longer than 15 years to translate the findings to the bedside. Maybe it's really hard for us to use low tidal volume if the patient is receiving pressure support ventilation or assisted modes of ventilation, even in well-conducted and large trials like the PREVENT trial. Maybe it's because we don't reassess our patients and retitrate the tidal volume. I love this data showing that the best predictor of low tidal volume in the ED is the use of low tidal volume in the ambulance, simply because maybe we don't have time to retitrate our tidal volume. Maybe because we don't measure our patients. This is data that we published showing that females are at higher risk of receiving high tidal volumes. And this is probably not because we are biased against female patients. This is probably because we don't measure our patients. And females are shorter, so they are at higher risk of receiving high tidal volume when corrected by predicted body weight. We also have data suggesting that we should aim for a low driving pressure, maybe a threshold of 15. Low mechanical power, we have data, but again, we don't do it. It's really hard for us to achieve like low driving pressure, and we don't measure mechanical power. So it's really complex. This is the situation, and it's really complex to ventilate patients. So in summary, the idea is always to prevent too high tidal volume, but it's really hard to achieve very low tidal volumes. We do not titrate according to sex, severity of the disease, or ARDS. We do not have time to reassess and change. Even the best PEEP, probably the best PEEP is the lowest PEEP, and the lowest PEEP can be 20, 25, it can be 5, I don't know. But generally, the PEEP table also provides a good PEEP for general population and as a starting point. And we should always aim for a low driving pressure and mechanical power. But again, it's hard, and most of the time we don't even calculate mechanical power at the bedside. So why automation? I don't have any disclosure, but I have maybe one disclosure that is important, that I use automation, and I use it a lot, like you. I love the interface of airplanes, like pilots and the automation. I love when Spotify and Netflix just suggest the next song or series based on an algorithm that basically knows what I like. So I really use automation. But in the ventilation field, why automation is important? Maybe because it can help us with immediate and automatic adjustments of the mode of ventilation in each clinical scenario. Maybe it can titrate the support that we give. Maybe it can start the weaning. Maybe it can improve the individualization of ventilation. Maybe it can even reduce the workload for the healthcare workers. So what are the present challenges that we have? This is an overview of the last 50 years of research in ventilation and ARDS. We did a lot of people from this room, they did it a lot. It's incredible, but it's like a puzzle. We have a lot of things to do, We have driving pressure, we have respiratory, we have PEEP, plateau pressure. Now we have P.1, we have expiratory occlusion pressure. We have a lot of things. It's really hard. And we have more challenges. We have a gap that is increasing between the supply and demand of doctors, intensivists or not intensivists. It will make things worse. We can have another pandemic, which will also make things worse. We have problems with doctors and healthcare workers leaving after the pandemic because of burnout. So everything will be probably worse. So what is the rationale for using automated ventilation? So this is the traditional ventilation that we do today. So we have a ventilator. We have the patient here. The ventilator provides a respiratory support. We get some information from the ventilator. and then we change from the patient, and then we change the ventilator based on that information. This is an initial idea of the automation. So we just provide some information to the controller of the ventilator. We set some targets. The ventilator provides the support to the patient, and then just do like a closed loop assessment of the parameters and the response from the patient. What do we need to have? So the first thing is that imagine this situation, the patient is receiving a ventilation with a stable minute ventilation. The end tidal is pretty stable. So the first thing that we need from automation is to have what we call the set point control. What is the set point control? It's basically, for some reason, I decided that I wanted a lower end tidal. So I just changed the set point here, and the ventilator responded with an increase in the minute ventilation, and then I achieved the new end tidal that I wanted. But the most important thing maybe is to have like what we call a disturbance rejection. Imagine a situation where for some reason the patient started to increase the production of CO2, and then to keep the end tidal stable, the ventilator basically automatically increased the minute of ventilation, avoiding fluctuations in the end tidal. So this is basically the two important things that we need from automation. And to end up with something like that, with protective ventilation, CO2 controller, oxygen, demand, and then always with this fully closed loop ventilation. Definitely ventilators are getting smarter, and I don't have any conflict of interest with that, but we have different types of automation. We have the smart care, we have the proportional assist ventilation, there is some kind of automation, and we have the ASV and the IntelliVent ASV, that is maybe what we have more advanced in the field. So with the new versions of the IntelliVent ASV, you can, for example, you can have automatic transition from different modes. You can have switches, and we can have changes in tidal volume and minute ventilation based on the Ortiz equation. You can have FiO2 and PEEP titration based on PEEP table. You can have, in some new algorithms, reduced driving pressure based on PEEP and low tidal volume titrations. You have the IntelliSync to automatically detect and treat asynchronous. You have the IntelliCuff to automatically measure the cuff pressure. So we have a lot of things that we can use at the bedside if we have the ventilator. So what's the safety, effectiveness, and efficacy of these different automated modes? So first, safety. It's important to first investigate if the ventilator is able to intervene when we have derangements. If it's possible, when it's, of course, if it's related with like a low incidence of severe adverse events. And of course, if the ventilator is able to prevent an unsafe ventilation. This is a systematic review just showing that the time that a patient is spent in critical zones of ventilation or unsafe zones of ventilation with IntelliVent ASV is really low. So it looks safe, but we need more data. Regarding the effectiveness, it's basically what we need is that the ventilator is able to just apply the appropriate mode of ventilation for each clinical situation, that the ventilator is able to like simply titrate the support that is using based on patient characteristics, and maybe to start weaning as soon as possible. This is real data from studies, just showing like how the mode behaves in different clinical scenarios. So we have normal patients with different severities of ARDS, and a COPD patient. So basically, let's start with the tidal volume. So from different patients, you can see that the automated mode is able to keep the tidal volume really low, and it can even achieve like lower tidal volumes in patients with more severe ARDS. It provides like more plateau pressure if the patient is more severe, so you can see an increase in plateau pressure over like in patients with severe ARDS. This is mainly related with the PEEP, so there is an increase in PEEP because it started using the PEEP table, so it's using more PEEP in patients with ARDS, so you have more. You have a higher plateau pressure, but the driving pressure is pretty low. You can keep the ventilation, keep the patient with a low driving pressure. And of course, there is an increase in the FiO2 requirements if the patient is more severe, but everything like an automated regulation of the ventilator. So we have some data. So this is really nice data from Amsterdam showing that in a crossover study using IntelliVent ASV and conventional ventilation and patients monitored with an esophageal balloon, just showing that patients receiving IntelliVent ASV basically received a ventilation with a lower transpulmonary driving pressure and transpulmonary intensity of ventilation. This is also true in real life in COVID. Again, a crossover study, conventional ventilation and IntelliVent ASV. IntelliVent ASV was associated with a reduction in driving pressure and in intensity of ventilation. And this is maybe, I think, still the largest trial in the field. This is in post-operative patients, in patients with after cardiac surgery. 220 patients randomized to IntelliVent ASV or conventional ventilation. Again, in the Netherlands, we did this trial in a very specialized setting with like very high ratio of nurses per bed. So with like mandatory rechecks every 30 minutes by the nurses and documentation of the ventilation parameters. And we use memory boxes to collect breath-by-breath data of all patients. And we can see here the primary outcome was the proportion of time or breath spent in different zones of ventilation, so optimal zones of ventilation, critical zones of ventilation, or acceptable zones of ventilation. The zones were defined based on the tidal volume, the maximum airway pressure, SpO2, and end tidal. And you can clearly see here that the IntelliVent ASV increased the proportion of breaths within what we call the optimal zone of ventilation and reduced the proportion of breaths in critical zones of ventilation. And this is a heat map just showing we have here patients. Each row is a patient. We have here moments. The first here is just exactly at the moment of randomization. Green is good, red is bad, yellow is okay. You can clearly see that at the moment of randomization it's pretty dispersed. 15 minutes after the randomization, you can clearly see here in the automated mode more green than here. So it's really quick, and the response is really... And in this specific trial, we just showed that even with nurses checking all the time, it's really hard for the nurses to provide like tidal volumes of like 6. I'm not saying that we need or we should use, but it's hard. And the IntelliVent was pretty okay, did it pretty well and reduced the tidal volume. Just weaned FiO2 quicker than the nurses or us. Like titrated the FiO2 in a way that it kept the patient in a conservative SpO2 target and reduced the mechanical power and the driving pressure. Again, no difference if you are a female or a male. There's nothing. You just have to set the ventilator, provide the height, and there is no difference anymore. So the tidal volume is always the same independently of your sex. This is one of the most exciting findings for the nurses and for the physios. The amount of interventions provided by the ventilator was much higher than the amount of interventions in the conventional arm. However, it's mainly driven by automatic interventions. And when we check just manual interventions, it reduced the amount of manual interventions compared with conventional ventilation. So reduce the workload for the nurses and for the healthcare workers. This is another study confirming this, like more interventions with automated ventilation, but a reduction in the manual interventions. And this is mainly related with a reduction of synchrony settings that you have to work, oxygen flush, and other settings that you have to do. It's also important maybe to save some oxygen, like we had a lot of problems with oxygen during the pandemic, and this is another study showing closed-loop FiO2 titration, just basically showing that the use of closed-loop oxygen increased the time that the patient is spending in an optimal SpO2 zone, reduced the amount of breath in the hyperoxemia zone, and the amount of breath in a hypoxemia zone. So it's probably important to save some oxygen. However, it's not easy to do, and unfortunately, it can be very expensive. It will help a lot of us in lower and middle income countries, like, for example, in Brazil, when we had like EDs completely full. When I did my training, we had sometimes 15 patients intubated in the ED, not in the ICU, because of the lack of our beds. We had like maybe 5 monitors for 15 patients. We had a monitor with a blood pressure from one patient, a heart rate from another patient, and the SpO2 from another patient. But it's really expensive. Maybe we cannot afford it. And especially we did this non-inferiority trial comparing basically side stream capnography and mainstream capnography, because we know that mainstream capnography is more expensive, but we were unable to show a non-inferiority. So side stream capnography is not non-inferior to mainstream capnography. So we need very specific sensors, and they are really expensive. What we have at the moment, so we are just running a trial. We have now more than 800 patients randomized comparing IntelliVent ASV and conventional ventilation. This is in Europe running now. We'll probably be finishing this in the next 6 months. And with a primary outcome of ventilator-free days at day 28. So this will be the first well-powered trial comparing completely automated mode of ventilation and conventional ventilation in patients, what we call without ARDS or with normal lungs. And we also have memory box data from more than 200 patients to check safety and things like that. It's a lot of data to analyze. So this is an overview. This is from Marcus Schultz, one of my mentors, and it's just like an overview of how we can use automation in the ICU. Closed-loop ventilation, it can titrate the tidal volume, PEEP, and FiO2. It can avoid potentially derangements, It can help with weaning and length of stay. That study that I showed in post-op ventilations in 220 patients, it achieved a shorter period until transition to assisted ventilation, and it was numerically almost achieved significance for time to extubation, but again, it was not powered for that. It definitely reduced the number of manual interventions and the human input required. So in conclusion, automated modes are there, and they potentially outperform healthcare workers. Probably they are not outperforming Laurent, they are not outperforming Leo, Rinaldo. Most of the audience here, they're really interested in ventilation, but they do really well. They are safe, they are potentially efficient, and probably we don't need to show that IntelliVent is better, just non-inferior, because we can reduce the workload. It supports the overtasked healthcare provider, reducing the workload. Challenge our availability costs. And I always like to say that the idea is to give control to the ventilator, but keep some control like the pilots do with aviation. Thank you very much.
Thank you very much, Ary. Great presentation, and we have time for questions. So maybe I'll start. So I was really, I like your disturbance rejection concept. I've been involved in the design of the smart care, and it worked pretty well to reduce the time of ventilation. But anytime there was a problem, people hated it. They did not understand what was happening, and there was nothing in the system to manage that. So could you comment a bit on this aspect?
Yeah, we have some data. We did some surveys with nurses asking about the mode itself. It's usually very positive. Of course, it needs improvement. It's usually easy to start the ventilation, and if the patient is okay, it will be okay. If the patient starts to deteriorate, it makes things a bit harder. Mm-hmm. So I don't think this mode should be used in patients like with more severe disease yet, like complex ARDS, COPD, asthma, and these kind of things. But for the majority of the patients that we ventilate in the ICU, short-time ventilation, they're probably okay, and the nurses usually they are pretty happy, but in a very selected setting. So I don't know if I use this mode in Brazil, if the nurses will be happy or the physios, but definitely something that we need to investigate.
Yes, question, Alexandre?
Alex Demoule from Paris, France. Thanks for your great talk. Just one question, because all those automated modes, they do exist for decades for the smart care, and IntelliVent is probably 15 years or more. And they have not been really adopted by physicians and nurses and teams. And how can we explain this? Because they look like safe, so why are we so reluctant?
I think it's availability, definitely. We don't have in Brazil, for example. Now we have, like we started having in Brazil in 2008 and 19 when we started using it in our unit, but it wasn't available in our units in Brazil. It's really expensive. It will not be a reality for low and middle income countries. We didn't have data, so we had some small studies showing, as you said, safety, but we didn't have like large trials like confirming. I think maybe as a doctors we are always waiting for like larger trials confirming safety and maybe effectiveness, which we now have and we probably have in the next year. So I think it's a combination of having more data, the availability of the mode, and of course as doctors for us sometimes it's hard to change and accept different things. So I think it just takes, like we saw with the low tidal volume ventilation, it takes a while.
Just one question. Do you need to sedate them frequently in automated?
To sedate them?
Sedation?
No, not necessarily. So this is what we found in the post-op ventilation study. It's basically like the mode is able to transition the patient from control to assisted ventilation, something that they call, like they says the quick win, the automatic SBT. So they don't need to be sedated. You can do assisted ventilation without any problem.
Very quick one, Leo.
So when we are, as doctors, at the bedside, looking at a patient on the ventilator, we take a lot of things into account, right? Maybe P.1, occlusion pressure, but also whether the patient is deteriorating or improving. If the patient is improving, we may be accepting higher P.1 and occlusion pressure. Do you think that this information is relevant for these automated modes as well?
Oh, definitely, I think, and it's changing, right? At the beginning, it was only using the Otis equation. Now some new algorithms are considering driving pressure. So I think we need, and you have a lot of papers on that, Leo, so you know that P.1 and expiratory occlusion pressures, and now they're really relevant. So it can potentially be incorporated, but they are not yet. So as I said, I think if the patient is a bit complex, maybe we should not use. and we should do what we usually do. But again, we have like a very experienced audience here. Maybe in most of the settings, 95% of the ICUs in Brazil, they will probably do better than having doctors not checking the patient.
Thanks so much. We have to move
Thank
on.
you.
Thank you so much, Ary.
So it is my pleasure to introduce Professor Rinaldo Bellomo from Melbourne, who will discuss how to assess respiratory drive during pressure support ventilation.
Thank you very much. Pressure support ventilation by invasive means is quite common where I work. It's perhaps a dominant form of pressure support assistance. But in terms of the epidemiology around the world, we don't know how often that's done. And so we wanted to start out by trying to understand how big an issue it is in Australia and New Zealand. So we looked at patients that were going to be ventilated for at least 7 days, and we looked at how much time they spend on pressure support ventilation in my world. This is a cohort of patients, you can see there, with a significant population, typical characteristics, and we had them selected because they had been on ventilation invasively for more than a week. And this is showing you how much time these patients spent on pressure support ventilation. It adds up to about 40% of their ventilation time, not on controlled ventilation, but on pressure support ventilation. So is this a good thing or a bad thing? Well, of course we don't know. But what is fascinating to me and Ary when we look at the data is that the behavior of clinicians practicing pressure support ventilation in these study centers in Australia and New Zealand is one of neglect. That is, they do set and forget. They put people on pressure support ventilation, they put them on 5 and 10, and they walk away. They don't look at anything that's happening, and they go and watch cricket. So what happens then when you're making that transition between mandatory ventilation and pressure support ventilation? That's an interesting question to look at. In our neck of the woods, what happens is as you transition, your tidal volumes go up, which may be undesirable, and the respiratory rate goes faster. And of course it's difficult because there are also transitions in sedation. This is a graphic representation. Immediately after coming on pressure support ventilation, the tidal volume goes up. The respiratory shallow breathing index doesn't change much, but then it goes up and the respiratory rate goes up. So there are changes in what happens to patients that are associated with this transition. The next question that we asked ourselves in this setting, are we helping people too much with the level of pressure support that we provide even in a neglectful environment? Let's find out. So we looked at whether over-assistance may be significant, and we can see that at even 10 of pressure support, we have a very high level of over-assistance. And the respiratory rate, the rapid shallow breathing index, and the P.1 can be used to assess whether there is over-assistance. And this data from a nice Brazilian study where they use esophageal balloon measurements to directly assess whether there is suppression of actual mechanical work and relate that to a variety of things that are available to us at the patient's bedside. And in Australian centers, you can see that over-assistance is very common in the setting that we provide to our patients. How big a problem is it? We did a multi-center study and we investigated the incidence of estimated over-assistance. So this is using the Brazilian study information. So if you have a respiratory rate of 17, you have a very high likelihood of over-assistance. If you've got a rapid shallow breathing index less than 37, you've got a high incidence or high likelihood of over-assistance. If your respiratory rate is 12 on pressure support ventilation, 100% of patients in the Brazilian study with esophageal balloon had over-assistance. And this is telling you that in a significant study involving almost 150 observations, the amount of over-assistance during pressure support ventilation in Australian centers is very common. Then there is the other side of things, which is your respiratory drive and your respiratory effort. And I'm sure many of the people in the audience will be familiar with the concept that we can estimate respiratory drive by measuring P.1, which is the pressure generated in 0.1 of a second of the respiratory effort. And of course, Leo here has done quite a lot of work to try and understand the significance of both the respiratory effort generated with the occlusion maneuver as well as the P.1 in relation to invasive measurements by esophageal balloon. And you can see that the relationship between these markers, such as the occlusion pressure and the P.1 with invasively measured pressures by esophageal balloon is really pretty good. And you can modulate it. And again, Leo's group have actually done some work to show that modulating pressure support in these patients may transform or attenuate the amount of effort that is in the physiological range as opposed to the incorrect physiological range, outside of the physiological range. So others have investigated these markers. This is Bertoni, again, looking at the value of occlusion pressure and using measurements by esophageal balloon to develop ways of being able to estimate what the muscular effort pressure is without actually having to measure it. And he conducted a number of assessments and developed a particular protocol of management, but he was able to provide information that makes it possible non-invasively to estimate these markers of respiratory drive and respiratory effort. When you do that, you can look at the changes over time in some of these markers and how they relate to the transpulmonary pressure. And again, you can see that a number of patients, there are situations outside of the physiological range. This is the receiver operating characteristic curve representation, looking at the relationship between estimated P-mus, the inspiratory effort, muscular effort, using the occlusion maneuver versus what you see by measuring it invasively. And you can see here that they're very closely related, and one is a reasonable predictor of the other. So armed with all of this wonderful work that's been done in terms of respiratory physiology during invasive mechanical ventilation, we went to try and study what might be happening to these markers of respiratory effort and respiratory drive in patients being ventilated by doing measurements every second day while the patients were twice a day while the patients were receiving invasive pressure support ventilation. And this is a cohort which has a group of patients with COVID pneumonia and a group of patients without COVID pneumonia. And this is the result of more than 500 measurements undertaken in these patients. And we were able to see that both P.1 and the estimated P-mus were high in about a quarter of our patients. And the presence of COVID pneumonia was a major determinant of the occurrence of elevated respiratory drive and elevated respiratory effort during pressure support ventilation. This is a graphic representation of the degree of respiratory effort in the patients with COVID and in the patients without COVID. There's a clear difference between the two. And you can see that persisting over time, over 3 days of observation during pressure support ventilation, the patients with COVID pneumonia clearly had a greater degree of respiratory drive and respiratory effort. And that is in numerical form. You can see that during pressure support ventilation, in patients with COVID pneumonia, we were in different states, in different patients, in a way that was difficult to predict by just looking at the patients. And you can see that in other patients, about a quarter of the time, you actually had over-assistance, but not in COVID patients. And in COVID patients, there was a much higher rate of under-assistance with higher respiratory drive. Of course, the two of them are linked. So your respiratory drive is going to influence your effort, and the two of them are nicely linked with a correlation, which is not perfect, but sitting around 0.79, 0.8. And that should not be a surprise because they are representations of connected physiological phenomena. But this is the thing that interests me the most. What do the doctors do in these states of non-physiologic respiratory drive, non-physiologic respiratory effort, either over assistance or under assistance during pressure support ventilation? And in true Australian tradition, they do nothing. And these are doctors that are blinded to our measurements. So we have all of this information, but we're not telling them. They don't know what's going on. They're practicing by looking at the patient, by looking at the level of P, by looking at the tidal volume, by looking at use of accessory muscles of respiration, by looking at the respiratory rate, by looking at everything that's on display, maybe doing plateau pressures, whatever it is that they do, and God knows whatever it is that they do or don't do, they are looking at the patient and they're making decisions day in, day out. And in response to what we know, is either over assistance or under assistance, which they're not measuring, they're doing nothing. And so there is what you could call the pornography of neglect undertaking in the Australian ventilation environment. So in conclusion, it is possible to non-invasively estimate respiratory drive and respiratory effort during pressure support ventilation if you want to. When they are measured, we can detect states of likely under or over assistance, and they appear to be common. Clinicians who are blinded to such measurements and to such data, who use clinical information as is available to them every day to make decisions, do not appear to make any changes that are synchronous to or responsive to or reflect the measurements of respiratory drive and effort. And so we're in a situation where we have some unphysiological states where we think we could actually address them, as Leo has shown in previous studies, by modifying and titrating the level of assistance, but they have not been tested in trials. And of course, the logic for wanting to test them in trials is to show that they're currently not being done. And I think I've shown you pretty conclusive evidence that they're not being done. And of course, with making changes and creating a physiological state of respiratory drive and respiratory effort by adjusting the level of pressure support ventilation to achieve that and monitoring and ensuring you've achieved that versus allowing neglect as it currently stands, whether that delivers better patient outcomes is something that we need to address in randomized controlled trials. Thank you very much.
Thank you. Thank you very much. Wonderful presentation. Are there questions from the audience? Maybe Laurent as well?
Rinaldo, thanks very much. It's really important to have this data. In one of the first slides, you show the way the patients were ventilated, and I was interested to see a lot of SIMV in the first days. So does it mean that pressure support is started relatively late, so that maybe before that there is already, I'm not talking of COVID, who as you said, it was a specific situation, but there may be even work to do before they are switched to pressure support.
I think you're right, and there's incredible variability of practice in response to people that have got a condition that in the mind of a clinician is likely to lead to prolonged mechanical ventilation. And that condition may be not a respiratory disease, maybe a neurological disease, like somebody with a major subarachnoid hemorrhage who's being ventilated. And in those patients, we often see tidal volumes of 1.2 liters, unless you sedate the patient. And in those patients, the practice is incredibly variable. So you might have some people that are sedated for a period of time, but then they are woken up to do neurological assessment, they transition to pressure support ventilation, and the level of pressure support ventilation is a random activity undertaken randomly by random doctors on a random day at a random time to achieve random goals without any idea of what it's actually leading to. And that's very sad. But it's very common. I mean, pressure support ventilation is very, very common.
Thank you very much. Other questions? Okay.
Thank you very much.
Thank you very much.
Thanks, Rinaldo. And we move on to Alexandre Demoule from Paris, who's going to say that P01 predicts almost everything.
Almost. Good morning to everyone. And it's my pleasure to give this talk on P01 predicts almost everything. So those are my disclosures, all in the field of mechanical ventilation, so somehow related to this presentation. So how to measure respiratory drive? That's the first question. So thanks to the previous speaker, Rinaldo Bellomo, you've been all initiated, if you were not, to P01. But let's remember how ventilation, spontaneous ventilation works. So the respiratory drive is initiated in the brainstem respiratory centers, and the signal is conveyed by the phrenic nerves to the diaphragm, which contracts, which in turn generates tidal volume and then gas exchange. So if we want to assess respiratory drive, we could measure the automatic activity of the respiratory centers within the brainstem, which is impossible in humans, possible in animal studies, but not in humans. We could measure respiratory motor neurons action potentials, also impossible in humans, nearly impossible in humans. Then the other option is to measure the depolarization of the diaphragm in response to the phrenic nerves activation. This is possible at bedside using EMG activity. It's a little bit invasive because we need to put a probe within the esophagus. And then we can also, that's the last option, measure the pressure that is generated by respiratory muscles in response to diaphragm contraction, diaphragm and all other inspiratory muscles contraction. So this is occlusion pressure at 100 milliseconds. So what's the principle? The principle is that here we have the airway pressure. So the airway are closed, and then the pressure generated by the respiratory muscle, we see the pressure is dropping when the patient is inspiring, and 100 milliseconds after the beginning of inspiration, then the pressure generated by inspiratory muscles is measured. So this is the P01. It's very simple. This is the P01. So why this P01? Why measuring pressure 100 milliseconds after the beginning of inspiration is so interesting? So first, because this is supposedly the occlusion of airway is supposedly not perceived by the patient because it takes 150 milliseconds to our sensory cortex to integrate the information that someone has occluded our airways. And after 150 milliseconds, we try to fight against this occlusion. So this pressure is supposed to be totally independent of the cortical drive, so the voluntary drive, respiratory drive to the diaphragm. It's a reliable assessment of the automatic respiratory drive, given the fact that there is no severe respiratory muscle weakness. It's independent of respiratory mechanics, and it's a little bit variable, so it's supposed to be more reliable if you repeat the measure, like over 3 cycles. So in most modern ventilators, this measure has been automated, in most with an occlusion maneuver that is performed, and the ventilator can measure this PO1. You see an occlusion. This is not the case in all ventilator brands. Some are more reliable than others. So this has been investigated in this paper by Irene Elias. So there's a nice comparisons of the reliability of different ventilator brands. And so here is an example of 2 different PO1 profiles. Just you know, an example. And we have here patients. We have so the flow and pressure trace in pressure support, and we have here a patient generating a huge inspiratory effort, and you see that this patient has a high PO1, suggesting a high respiratory drive, and this patient has a low respiratory drive, so you see that PO1 is low. So this gives you an image of what's a small and a high PO1. So let's back to our respiratory drive and why it could be interesting to measure PO1 to predict many things. So the determinants of respiratory drive is mostly the respiratory system loading capacity balance. And when we have a too high respiratory system loading and impedance due to high resistance and elastance, in front of a too low respiratory muscle strength and also too low level of respiratory assist, then this increases respiratory drive, which is also influenced by metabolic stimuli such as hypercapnic acidosis and some cortical inputs, of course. So PO1, so the determinants of PO1 have been evaluated quite recently in this study by Elena Spinelli, and they show that really PO1 was quite well influenced by the usual suspects. All the usual determinants of respiratory drive were actually associated with PO1, which really suggests that PO1 is an interesting surrogate of inspiratory drive. You see that P2F ratio, ventilatory ratio, which is a kind of approximation of dead space, the severity of the disease in terms of pulmonary infiltrates, the pH, and also PEEP. So this suggests that this PO1 is a quite well surrogate of inspiratory drive, and then see there's some attempts to evaluate whether or not a low or high PO1 could predict something. And in this nice study in COVID patients, the authors, they measure PO1 in patients during the transition phase, so after they have been switched from controlled ventilation to pressure support. And what they noticed is that patients with a high PO1 were more likely to have a respiratory relapse and then being resedated and switched back to control mechanical ventilation, whatever the cause of this relapse. So what we try to assess is can we predict more things with PO1? So could PO1 help us to detect dyspnea? Could PO1 predict the remaining duration of mechanical ventilation? And could PO1 predict survival? So in a secondary analysis of study we did perform in mechanically ventilated patients, all intubated, we analyzed the 260 patients in whom the PO1 had been measured. So they were basically all under pressure support ventilation. They were awake, which is quite particular, and able to communicate. That was the inclusion criteria of the parents in the parent study. So they were able to communicate. Why? Because we wanted to be able to collect the data on dyspnea, whether those patients had dyspnea. So they had to be communicative. So PO1, you can see that we divided PO1 in like low, abnormally low, normal, and abnormally high. So with two kind of values, which were 1.5 and 3.5. And you see that 39% of patients had a low PO1, 37% were in what we define the normal range, and 24% had a high PO1. So the first question we wanted to address was whether or not PO1 could help detecting dyspnea. So why this dyspnea story? Because dyspnea, which is the abnormal perception and abnormal perception of breathing, which is basically respiratory suffering, which is, the patient would say, suffocation. So that dyspnea is partly and mostly determined by respiratory drive. So patients with a high respiratory drive should have a high level of dyspnea. And we noticed that the proportion of patients with dyspnea was much higher in those with high level of, there's a mistake here, it's 50%. So the higher the PO1, the higher the prevalence of dyspnea. And in multivariate analysis, dyspnea was independently associated with PO1. So there was an independent relationship between dyspnea and PO1. So this answers the first question. PO1 can help us to detect dyspnea. Second question, could PO1 help us to predict whether the remaining duration of mechanical ventilation will be long? Well, the first paper I show you regarding relapse suggests that yes, because if there is more relapse, probably there will be a longer remaining duration of mechanical ventilation. And also because we know that weaning is determined by the load capacity balance, and a load capacity unbalance is associated with high PO1. And yes, here in this study, what we observed is that the probability of weaning from mechanical ventilation was lower in patients with high PO1. And here again, there was an independent relation between PO1 and the remaining duration of mechanical ventilation. Finally, the last question we addressed was the relation between PO1 and mortality. But we can infer that if there is more respiratory relapse, if there is a longer remaining duration of mechanical ventilation, well, patients with a high PO1 should be more likely to die. But this is maybe also, a chicken and egg story, because patients who have a high PO1 maybe will generate higher inspiratory efforts and then could generate PSILI, patient self-inflicted lung injury, and ventilator, associated lung injury, so a mixture of both. And what we observed is that the patient with a higher PO1 had a lower survival probability. What really surprised us is that in this case, patients with a very low PO1 didn't have a higher mortality. And what we anticipated is that mortality could be also higher in patients with a low drive. That was not the case. And we had a quite significant relationship between mortality and PO1. And here again, PO1 was independently associated with mortality. So PO1 seems to be a good surrogate of respiratory drive. And we can say that a high PO1 is associated with a higher prevalence of dyspnea, a higher risk of respiratory relapse, a higher duration of mechanical ventilation, and a higher mortality. So it predicts almost everything. Now the problem is that we don't know how to use it. And that's the question Rinaldo Bellomo raised before, is now I have an abnormal PO1, what do I do? And probably why Australian doctor didn't change the settings, we don't know what to do. And that's the new challenge we have. Thanks very much for your attention.
Thank you so much, Alexandre. We have time for questions. Domenico, you had one question.
Congratulations for the paper and the presentation. I was just looking at the Kaplan-Meier about mortality with low PO1 showing better mortality than high PO1. Better survival, sorry.
Yes.
Does it mean
high PO1?
Worse survival?
Yes.
Does it mean that in a way under assistance with high PO1 is worse than low over assistance with low PO1?
I cannot answer the question because we don't know. That's not an interventional study. So, and that's the whole story of because we are right now we don't know, we don't have information on whether or not changing ventilator settings to target a given PO1 will affect survival of patients. And you know, this is like the milestone. So now we need those trials. We need those trials who going to tell us, give us kind of algorithms to guide our mechanical ventilation, the way we deliver mechanical ventilation, and whether or not we should achieve among goals PO1. Because, for instance, we know that in patient under controlled mechanical ventilation, we should achieve a plateau pressure that is below 28. Okay, that's done. It's not done but that's evidenced. But now what about PO1? And I don't have the answer. So I can say it predicts, but not what should we do.
But just to continue, I agree we need trials, but we also need to understand exactly what's the situation now.
Yes.
And maybe not with mortality, because but with duration of ventilation, we would expect kind of a U-shaped curve, that patients with very low PO1 over-assisted, they have longer duration of ventilation compared to normal range of PO1. And that's not exactly what you showed.
No,
right?
exactly. This is exactly what we expected. We expected, so when, no, it's too late, but there's a difference between the shapes here, between the three. And we expected that duration of mechanical ventilation would be longer in patients with a low PO1, like, the lazy breathing. So, and the lazy diaphragm and the lazy drive. So more mechanical ventilation.
The lazy
longer.
doctor?
Yes. No, I don't know. But no, and we were very surprised, and I cannot explain this right now.
Thank you. Thank you very much.
Thank you.
From Nijmegen in the Netherlands, we'll discuss how to modulate high respiratory drive. Thank you, Leo, please.
Good morning, everyone. Thank you very much, Domenico. How to modulate respiratory drive. So these are my disclosures. I don't think anything related directly to this presentation. And first to start, what is respiratory drive? As explained by the previous speakers, it's the neural output of the respiratory centers. And right here you see a schematic of the brainstem. And the brainstem contains the respiratory centers, and the activity of the respiratory centers depends on feedback from the body. Let me get into a little bit more detail. I know it's Friday morning, but still I want to go a little bit deeper into the physiology because I think it's exciting and I'm going to show you it's important. So right here is a schematic of the brainstem. So there's a couple of centers that are really important. Right here, the pre-Butzinger complex. That's an area in the brainstem that contains interneurons that generate the rhythm of inspiration. So these centers generate respiratory drive, and these are tightly connected to this ventral paraphageal region that is connected to the cerebral spinal fluid. So this area contains H+ receptors. So if H+ increases in your cerebral spinal fluid or pH decreases, there's more activity of these receptors and more activity in the pre-Butzinger complex, more respiratory drive. And we could talk for hours about this specific picture, and if you're really interested, I can highly recommend you to read these two papers, but it is important. So, the first feedback from the body to the respiratory centers is chemical feedback. As you're sitting here in this room, the reason why you have respiratory drive is arterial CO2 or arterial pH. Again, I'm not aware of any CO2 receptor in the body. It's all regulated by H+. But a little bit increase in arterial CO2 has a tremendous effect on minute ventilation. What about PaO2? Is that a determinant of respiratory drive? Well, not so much. As you can see right here, arterial PO2, minute ventilation. Arterial PO2 can decrease from 120, 180, little bit of effect on minute ventilation. Only when arterial PO2 is below 8 kilopascal, 60 millimeters of mercury, there is an effect on minute ventilation. So chemoreception is the first feedback mechanism. The second is cortical feedback. Everyone working in a neuro ICU will recognize that a lot of patients with traumatic brain injury, but also patients with delirium, do have a high respiratory drive. As you're sitting here in this room, the cerebral cortex has an inhibitory effect on the respiratory center. So when there's brain damage, we lose this inhibition and respiratory drive increases. And thirdly, reflex feedback. So there are J receptors, irritant receptors, stretch receptors in the lung, in the chest wall, in other parts of the body. And when these are activated, for instance, by inflammation, by infection, respiratory drive increases. You will recognize that. If you see a patient in the emergency department with a pneumonia, with pulmonary embolism, typically pH is 746, 745. For this reason, activation of irritant receptors in the lung. So to summarize, activity of the respiratory centers, respiratory drive is determined by at least, and this is a simplification, but at least 3 feedback mechanisms. Chemical feedback, cortical feedback, reflex feedback. Respiratory drive should result in respiratory effort, which is really different. That's also explained by the previous speakers. And respiratory effort is determined by activity of the respiratory pump. So why are we discussing this? Why is this important? Well, I think that Alexandre has explained as well. In patients with low respiratory drive and effort, they're at risk for respiratory muscle atrophy, poor patient-ventilator interaction, sleep fragmentation. While on the other hand, if respiratory effort is high, this may result in lung injury, maybe diaphragm injury, hemodynamic consequences, and a high respiratory drive is associated with dyspnea sensation. I'm not going to discuss how to quantify drive and effort. That has been done extensively by the previous speakers. But the important part here is, how do we modulate it? Well, then again, we need to go back to the physiology. Here you see respiratory drive, the 3 input pathways, cortical, chemoreceptive, mechanical. So changing the cortical stimuli, it's sedation, treatment of delirium agitation. Changing chemoreception, extracorporeal CO2 removal, but also by changing your ventilator settings, and the same thing is for setting your level of PEEP. We're going to discuss that in a little bit more detail. So first is patients on pressure support recovering from pneumonia, ARDS. Pressure support of 12 in this case. Tidal volume around 10 ml per milliliter. If we decrease pressure support to 6 centimeters of water, you'll see tidal volume decreases a little bit. But at the same time, electrical activity of the diaphragm, the best estimate, as Alexander explained, of respiratory drive increases. So we can modulate respiratory drive by modulating inspiratory assist. But this is interesting. So what is the effect of PEEP on respiratory drive? Very nice study published in the Blue Journal a couple of years ago. Patients with ARDS, wide range of PF ratios. And what you see right here is the airway pressure. And right here swings in esophageal pressure, which represent inspiratory effort. So what they do here in a representative example, the only thing they change is increase PEEP from 5 to 15. And what you'll notice right here, that the swings in esophageal pressure actually decrease by only changing the level of PEEP. So higher PEEP in this situation decreases respiratory effort. And this is for the whole group. Higher levels of PEEP from 5 to 15, lower changes in esophageal pressure, lower effort. And that decreases tidal volume. So what is the mechanism? How does an increase in PEEP change respiratory drive? That was actually quite confusing, because in some patients increasing PEEP, respiratory drive increased, while in other patients it decreased respiratory drive, as you can see right here. Honestly speaking, if you try it in your own ICU, well, no, at least in my ICU, it is not as consistent as you see here, that increasing PEEP always decreases respiratory effort, but these are the findings of this group. But very interestingly, I think actually published a couple of days ago by Domenico Grieco in Chest, he basically did more or less the same study. People 5, people 15, and this is what I see in my ICU as well. Different level, higher level of PEEP. In some patients, tidal volume increases. In other patients, it decreases. Respiratory effort as changes in esophageal pressure. In some patients with higher PEEP, effort increases. In other patients, it decreases. And this is a quite complicated figure, but I'll get you through. So right here, it shows the change in respiratory compliance with increasing PEEP. So these are the patients with increased compliance and higher level of PEEP. And right here, this means reduced effort at higher PEEP. So if with higher PEEP, compliance increases, effort will go down. And these changes in respiratory compliance exclusively result from the changes in lung compliance. Okay, so let me try to summarize this. So, if we increase PEEP, in some patients respiratory drive decreases. Respiratory effort decreases. My hypothesis is, but it's a little bit challenged by the findings from Domenico, it may be the result of increased lung homogeneity, because I tried to explain you earlier, if there is consolidations in the lung, it activates irritant receptors that increase respiratory drive. While in some patients, increased respiratory drive, higher PEEP, increases respiratory drive, but decreases effort because there is an impaired neuromuscular efficiency. For this reason, this is the diaphragm. right? And you know, for every muscle, there's an optimal length for muscle contraction. If the muscle is overstretched, you can generate less pressure. If the muscle is too short, you can generate less pressure as well. So we have shown in patients in the MRI that increasing the level of PEEP shortens the muscle. So if the muscle becomes shorter with PEEP, the muscle becomes less efficient, you can generate less force. So I think the effect of PEEP on respiratory drive is complex, but I just try it in your ICU. I think it's really surprising findings. But in most patients, a higher PEEP has a variable effect on drive and effort. If there's a reduced breathing effort, this could be due to a lower respiratory drive or due to an impaired neuromuscular efficiency of the muscle. Okay, we can also modulate drive by sedation. Right here, nice study from the group of Paolo Navalesi at different levels of sedation using propofol. Right here, respiratory drive is assessed by electrical activity of the diaphragm. The higher the level of propofol, the lower the electrical activity of the diaphragm. So propofol is an excellent agent to modulate respiratory drive, but not opioids. Sometimes people try to modulate respiratory drive using opioids. So this is from the same group at different levels of remifentanil. As you can see right here, under control conditions, with remifentanil, the respiratory drive, the amplitude does not change. The only thing that changes is the respiratory rate. So nicely shown here, the higher the level of remifentanil, the electrical activity of the diaphragm more or less remains the same. So if you want to modulate drive, you should not use opioids. Same thing here, so it's summarized right here. If you want to modulate respiratory drive, benzodiazepines or propofol are the way to go, but not opioids and also not dexmedetomidine. That has limited effect on the respiratory drive. Of course, you can modulate respiratory drive using extracorporeal CO2 removal, very nicely shown by the group of Tommaso Mauri, changing gas flow during ECMO. You can see the higher the gas flow, lower the tidal volume, lower the pressure generated by the muscles. But I don't think this is very feasible in clinical practice. So to summarize, if your patient has a high respiratory drive, it starts with physiology. Try to understand why respiratory drive is indeed high. And if you understand that, it makes it easier to make a choice for one of these options. We've nicely tried to summarize that in these two papers that have been published in the past few years. And my final slide right here, what I've tried to show you, that respiratory drive depends on chemical, cortical, and reflex feedback to the respiratory centers. If you modulate drive, you can do so by just turning the knobs of the ventilator a little bit, inspiratory assist, maybe the level of PEEP, or if that doesn't work, decide upon your level of sedation, treatment of pain, dyspnea, or delirium. Thank you very much.
Thank you very much, Leo. We have time for questions. Ary.
Leo, quick one. Can you just explain a bit on the partial paralysis, like the actual state, research, and practice on that?
Yeah, so I didn't show that, but if patients do have a high respiratory drive on a pressure support, and if these patients are well sedated, we did a trial a couple of years ago, a pilot trial, and demonstrated that with low dose of neuromuscular blockers, so the partial neuromuscular blockades, you can actually titrate your level of your tidal volume, the pressure developed by the respiratory muscles. But this is still, I mean, this was a pilot study, right? It's not something I would recommend right now. I think it's an excellent concept to deliver lung protective ventilation under pressure support. I mean, you still have the benefits of an assisted mode. The respiratory muscles are active. But the long-term outcome, I don't know. The other problem is I think it needs a high level of sedation because the respiratory drive in these patients will still be very high. So if we believe, and I believe Alexander always, these patients probably have a high dyspnea sensation. So this is something that we are actually working on. I think the concept is really interesting. But we need to take care about how we can modulate the sensation of dyspnea in these patients, because it would be fantastic if we can wake them up, if the drive is high, give them a little bit of rocuronium or neuromuscular blocker, but keep them awake and modulate the dyspnea sensation.
Leo, I wonder if you could comment briefly on the fact that many people, when they think of respiratory drive, they look at the respiratory rate, because it's the easiest thing to measure, but can you comment on the difference?
Yeah, I think these are different entities. Patients can have a high respiratory drive, so a huge amplitude, probably a huge dyspnea sensation, but a low respiratory rate. Again, if you go back into these Nature papers where I started with, there are different centers in the brainstem that regulate the amplitude of drive and different centers that regulate the rhythm of respiration. So I think that you still can have a very high respiratory drive with the disadvantages of that and a relatively low respiratory rate. So it doesn't necessarily mean if the respiratory rate is low that the drive is low.
Or the opposite, right? The Navalese paper, it was a very nice figure where you see the amplitude decreasing, but the rate
increases. That's right. Yeah.
Thank you very much.
Thank you.
Thank you,
Leo. So it's my pleasure to invite J Marini, well known to this audience, and going to discuss estimation of the hazardous component of ventilating power.
Thank you, Laurent, and good morning, everybody. My problem here is to sharpen our understanding of what ventilator power is in terms of the damage that it can potentially hold for the injured lung. And as I think we know, from the year 2000 to the current 2024, we went from low tidal volumes to low plateau pressures, to high PEEP open lung approaches, to low driving pressure, to prone positioning. Now we're concentrating on low ventilating power as a component. And we'd like to eventually get to the point where we can talk about the reducing the damaging power and the cumulative injurious strain to the lung, which probably causes ventilator-induced lung injury.
Okay, that's why I started.
Energy is needed to inflate the chest, and it is a pressure volume product. So if we look at constant flow ventilation, therefore the horizontal axis becomes the volume axis, and the airway pressure axis has a flow resistive component A, a driving pressure component B, and a PEEP related component C. A, B, and C together accumulate to the inspiratory energy that's elastic in the energy equation. So energy is volume times the total pressure, which has the component A, which is a flow resistive component, a driving pressure component, the average driving pressure component, which is the integral of flow divided by compliance, and positive end expiratory pressure. Now, if we take energy per cycle and increase the frequency over a minute, we've come to know that as power because it's energy per unit time. But it's a very strange form of power. It's actually just cumulative inflation energy over the period of a minute. It's not really the intensity of the force that's damaging the lung. And I'll try to explain more what I mean about that as I go on. Power is cumulative energy per minute, as I just mentioned. Power, then, is minute ventilation times the average pressure, the mean pressure, and it has the same components as the individual cycle. But the factor here is minute ventilation, which includes not only volume, but of course frequency. The three primary determinants of Villi risk, the mechanical stimulus for Villi, is certainly power, but that's affected by the duration of high power exposure, the frequency of high stress cycles, and I emphasize high stress here, and the damaging energy per cycle, which is conditioned by the vulnerability of the tissue and the amplifiers of the risk to the individual component of the cycle. So I think we all know that principles from the year at least 2020 till now. We're thinking in terms of power and driving pressure and you know the value of prone positioning to try to even out the heterogeneity and the vulnerability of the lung. Where do we go from here? Pressure, volume, and total power are all Villi correlated, but they're imprecise determinants of the cellular strain and hazardous tissue stretch that we are really concerned about. And we have to ask ourselves, could we do a little bit better than just measuring at the airway opening the flows, the volumes, and the pressures? Can we estimate the true risk of Villi just a little bit better? And this is really a conceptual talk. So please don't take it immediately to the bedside, but I want you to think about these questions. When you talk about power, and you tell me that a power level of 17 joules per minute is super dangerous because it's correlated with mortality, to me that makes an impact, but it doesn't make any sense. Until you know the size of the baby lung that you're putting that power into, you don't know the specific power and the stress and strain that's going into the tissue. Unlike pressure, which we can measure, the baby lung concentrates power. And to know that concentration, we must know the FRC of the baby lung, which we don't know and we don't measure at the bedside. That should cause us a little bit of concern. For specific power, now specific power I mean relating to the small baby lung, we need to consider the resting volume or the FRC. The specific power is the measured power, and it's, if you want to make a simple comparison here, if I put an airway pressure of 30 centimeters of water into this large lung, I have a global power of 4 joules per minute. I do the same thing for this baby lung. I have an airway pressure of 30 centimeters of water and a global power of 4 joules per minute. But the specific power that's going into that baby lung is much, much greater. Unmodified energy and power are not enough. Damaging energy also requires a high stress and strain threshold to be crossed. Let's say we have a pressure, this is an alveolar pressure, that's high enough as we raise the volume close to it and get to that point. Any further volume increase and pressure increase delivers an energy, a damaging energy, or potentially damaging energy, that's quite different than what we currently measure as the general power. And you might say, what's the threshold? And that's a good question. What is that threshold pressure that we're concerned about? Well, the different locales in the lung, high and low, will have different thresholds that we have to concern ourselves with. For example, if we're actually at this point high in the lung, where we already have a fairly high pressure, then the threshold pressure that we need to cross is actually quite small. Whereas in the dependent area here, we have actually a fairly high level of additional pressure that we need to apply to get to a threshold. The point here is not the numerics of what I'm talking about, but that different locales in the same lung have different thresholds and vulnerabilities to stretch. That's not talking about the amplifiers of stretch, which occur in the dependent areas, which I don't have time really to talk to about today. Again, let's look at our pressure versus tidal volume relationship here. Volume on the horizontal axis, pressure on the vertical axis. And we're looking at elastic pressures here because this flow resistive pressure is probably not numerically related to the energy that we're worried about. The energy of the total cycle, which goes into the power that we compute, has basically a safe zone and an unsafe zone, depending on whether or not we've crossed the pressure threshold. The pressure threshold varies with the vulnerability to injury. And as in medicine, we tend to say this is a safe pressure, this is not a safe pressure, but we forget that the lung is changing continuously from a fairly vulnerable lung in the early part to a less vulnerable lung in the latter part. And in the latter part, we may have a smaller lung, which has a higher energy, specific energy, but less vulnerable to stress and strain. So it's quite complicated in some ways. Just putting this as an illustration. If I have a threshold pressure that's at this high blue line, and I have 5 cycles, and I have a PEEP component, and I have a driving pressure component, and I do never reach the threshold level, this is relatively safe power. If I'm exercising, I generate many, many joules of energy over the course of a minute, possibly 60, possibly 100, and I don't damage my lung. But in the setting of ARDS, we may have a threshold pressure that we cross with our elastic pressures, and then we accumulate these damaging pieces of energy. That will give us at a respiratory rate of 16, a damaging level of energy and power. If I reduce the number of cycles, but increase the tidal volume, I still can generate the same level of damaging energy. If I were to keep the same tidal volume as I had before, then I would have less damaging energy produced. Can we estimate how much of the energy per cycle is damaging? And the answer is probably no. But in a paper that we've written, if you're looking at just driving pressure and looking at the hazardous ratio, how much energy above the hazard are we generating above the driving pressure that's dangerous? It's a fairly simple equation. It relates to the threshold pressure, it relates to the plateau pressure, and it relates to the driving pressure. And these are the two simple equations. One if you're concentrating on driving pressure, one if you're concentrating on plateau pressure as what you're concerned about. So what is that threshold pressure? I simply don't know, but at the bedside right now, we use 15 centimeters of water for a driving pressure and 30 for a plateau pressure. That's a start. It's just a start. But now here's the important and challenging piece of my talk. The villi action is not inside the alveolus. We can measure pressure, we can measure volume because they communicate via the air channel that leads us to the airway opening. But what are we really concerned about? We're concerned about the cells and vessels at the periphery. And those are subjected to hoop stresses. And those hoop stresses are associated with tension. And what is tension? Tension is force not per unit area, that's pressure, but tension is the ripping force or the force per unit length. And that's at the periphery of the alveolus that we're so concerned about. You've all heard of the law of Laplace, and you know that tension is the product of pressure times radius divided by a coefficient, in this case 2. When I put energy into the alveolus, which we're representing by a sphere, that same energy is distributed on the surface, but in a different way. It's not pressure and volume anymore. It's tension and area change. Tension and area change. They sum to the same amount of energy, but they distribute the ripping forces differently and the straining forces differently. If I take an alveolus that has normal thickness and a normal resting lung volume, and I compress that alveolus to a smaller volume, I have a normal thickness but a reduced volume, I have a bigger thickness, I have a bigger denominator, and the tension is less. If, on the other hand, I take that same alveolus and expand it, I thin the margin, which actually reduces the denominator, I increase the radius, and I increase the pressure, and I increase the tension. I don't know how many of you have seen patients at the end stages of COVID-19, but they have cysts that form. There's a tendency to coalesce individual alveolar units into cystic form because there's more damage and stress and strain occurring in that setting. We can talk more about that later if you so choose. So this is theory. If we consider tension, what does that really imply? It implies that a lower resting gas volume, or FRC, is an important contributor to tissue tensions during tidal volume delivery. If I deliver the same tidal volume with a smaller FRC, I increase the tension at the end of inspiration and cause more damaging tension and pressure. Higher pressures at membrane thinning lead to a tendency to merge alveolar volumes and cause this formation. If we recruit without overdistending, that lowers the membrane tensions and ripping forces. And end-tidal hyperinflation causes mechanical paradox during chest wall loading, as we've talked about earlier in this meeting, and I think most of you know that when you push on the belly, sometimes the plateau pressure goes down because you're overinflated at the end of inspiration. We need an estimate of FRC. Finally, what about that local stress focusing that I mentioned before and that you all know about at the junctions of closed and open lung units? Local stress focusing increases tension and strain. If we have a reluctant left lung unit to expand and surround it with other lung units that are expandable, we generate excess pressures and forces and energy loads at those junctions in a simple spherical model. And in a paper that's just been accepted, we could compute the interface stress multiplier of tension between a low compliance area and a higher compliance area of a similar volume, an interface strain multiplier of area, which relates to strain by a ratio of the relative compliances and exponents to those equations. I don't want to go too deeply into that because it's theoretical, but I think using bedside parameters, we can actually use it. Final slide. Total elastic energy. Okay? And we have frequency. Total elastic energy and frequency, we get the elastic power. This is more or less what we currently use. If we relate it to the size of the baby lung, we have a specific elastic energy. And the specific elastic energy eventually distributes into tension and area change, or incremental surface area change. And when we go down the line here to incremental stress and strain, we could get to the Willi risk per interface. And if we know the interface proportion, which we can estimate in that paper I just mentioned to you, we get the Willi risk per cycle. We multiply that by frequency, and we come much closer to Willi risk. These are conceptual thoughts, but really, we're guaranteeing ourselves pressure and volume and flow, and maybe the action and some of the confusion we have relates to something different, tension and the area and strain shift that's happening at the periphery of the tissue. Thank you.
Thank you very much, John. Maybe one comment, because I like very much your idea of a threshold, right? Below the threshold, you may not see much. I would argue that you need also a lower threshold, because I'm concerned by people saying, well, let's go to lowest PEEP, lowest power, and at very low FRC, the pulmonary vascular resistance are very high, and we need some PEEP to restore some lung volume to protect the right ventricle. So I would say we need a window of values with a low and a high threshold probably.
Yeah, that's absolutely right, Laurent. We need to expand the size of the baby lung so that when we do that, the end inspiratory stretch that we have is less than it would be if we have a smaller baby lung. There are many interesting little pieces to this puzzle that I've just put in front of you, but I believe, quite strongly that the physics will tell us that this is the direction we should go.
Thank you very much.
Thank you very much, John.
Thank you.
So it is my pleasure to introduce our last speaker, who is Konstanty Szuldrzynski from Poland, who will discuss the role of flow-controlled ventilation as a novel ventilatory modality. Thank you.
Thank you, Domenico, for this very kind introduction. I hope you'll notice that my family name will be the most difficult part of this talk. So, what about flow-controlled ventilation, something completely new? How can it be applied in clinical practice? It doesn't make sense. So these are my disclosures. None of them have anything to do with this topic. We wrote this review paper having little amount of data just to explain the principles of modality. Because if we look at the curves, and especially the flow curves during mechanical ventilation, whatever the mode we use, you can easily notice that the expiratory flow every time looks the same. Why is that so? It is because irrespective of the type of the ventilator we use, and irrespective of the type of the mode that you select, you always have the same mechanism, because all you control is the inspiration. So they all act like this internal combustion engine, and they look different, but the principles are exactly the same. This is something different, in fact, because this was the iron lung, and so far that was the only modality, the only technological solution that allowed not only to support inspiration, but also to support expiration. However, as the airway was not controlled in this mode, we could not control the expiratory flow. So what we could do was support expiration, quite unlike in the conventional modes, but we could not control the expiratory flow. So this new modality's novelty is based on completely different principle of expiration, because what we get is an active and supported expiration. So the expiratory flow looks like this, right? Constant inspiratory flow, constant expiratory flow. And the resultant pressure curve looks like this. Completely different, right? So when you add this flow-controlled ventilation, you see that flow pattern, especially expiratory flow pattern, is completely different. And this is the novelty. Why was it invented? Because some anesthesiologists experienced real trouble while ventilating the patient via very, very narrow airway, very, very narrow tube, which was necessary, for example, for upper airway surgery. Because inspiration, for sure, is simple, because you can perform it quite easily with jet ventilation, can't you? But what about expiration? You cannot control it. What you get is CO2 accumulation, right? So how about we invent something that is based on Venturi's effect that can also support expiration in an active way? And this is what they developed. It was quite simple, but the entire ventilator is based on this principle and on this invention. They have a patent for that, and then they started testing the solution first in surgery, so that in anesthesia. And it proved to be quite useful in various applications, right? Okay, there are also some observational studies. This is only for anesthesia. What is interesting in these animal studies is that you can get very good gas exchange, very good CO2 clearance, and very good oxygenation with a lower minute ventilation. Look at the upper graph. There you have minute ventilation, and you have better gas exchange with less minute ventilation. So that could be useful, especially because when you look at this analysis of the CT scan, you see that you have better aeration and less collapse in the lung. So you have better recruitment in the lung, right? Okay. They also calculated that controlling both inspiratory and expiratory flow can have positive impact on the amount of mechanical power that is delivered in terms of dissipated energy. If you prevent the lung from uncontrolled collapse and uncontrolled expiration, you can probably attenuate the amount of energy delivered, which is quite interesting. Here you can see in another model, also in pigs, in one lung ventilation. Sometimes you have to ventilate one lung in cardiac surgery or thoracic surgery, that you can apply lower mechanical ventilation, lower mechanical power compared to volume-controlled ventilation, and the outcome in terms of gas exchange was similar. Also, they performed some EIT assessment, and it proved that the distribution of ventilation was also better, probably due to equalized emptying of the parts of the lung with different time constant. And this is the last study in animals that was performed and published quite recently in this year in a porcine model of abdominal hypertension, which you can compare to for example, robotic surgery or laparoscopic surgery, and they noticed again that even in high intra-abdominal pressure, what you get is less collapse and better aerated lung. And they also added this microscopy, and you see that especially on the third graph on your right, you can see that even with high intra-abdominal pressure, the homogeneity of ventilation during flow-controlled ventilation was better compared to pressure-controlled ventilation. So this is really, really interesting. In this part, you can see that the mechanical power was lower despite of and the minute ventilation was also lower with the same amount of gas exchange compared to pressure-controlled ventilation. So, what the inventors tried to prove is that it can be also used in humans. Unfortunately, due to the nature of the method, you cannot use it for assisted ventilation. So it can be used only for patients who are absolutely passive. So the population they picked was moderate ARDS, completely passive patients, not so huge numbers of patients, but you can see that that was feasible. There was no significant difference in terms of oxygenation using flow-controlled ventilation, and the CO2 clearance was also similar, even though minute ventilation was smaller and significantly lower compared to conventional ventilation. There is only one product that provides this. It's produced in the Netherlands, as far as I remember. There are different solutions how to deliver this kind of ventilation into the human. There is a tri-tube, so very small tube designed for upper airway surgery or single lung ventilation, or there is an adapter that you can be used for normal endotracheal tube. This is what the user interface looks like. What you set, in fact, is FiO2 inspiration flow and inspiration to expiration ratio, and also the upper pressure and the lower pressure. These are all the settings that you can apply in this mode of ventilation. We have some experience with that, mainly in surgery, but also in COVID. We tried it in COVID. So this, basically, it's interesting and it's quite useful for narrow airway, right, for anesthesiology. It provides surprisingly effective and safe controlled ventilation. Interestingly, it delivers less mechanical power and less dissipated energy compared to conventional modes. Compared to these conventional modes also, the distribution of gases and the distribution of tidal volume within the lung seems to be improved with this modality. But, there are several buts, it's only available in passive patients. Second is, there is absolutely no backup mode. So there is either flow-controlled ventilation or jet ventilation in this machine, and absolutely no backup. It is driven by the pressures that are measured inside the trachea with a special catheter. Once this catheter becomes congested by exudates or whatever, it stops working completely. So you cannot use it unattended. Sometimes also the driving pressures might be high. You cannot leave the patient alone. So you need at least one nurse looking at the patient. So we tried to join this clinical study during COVID days, but it proved to be completely impractical so far. So This is all. Thank you very much.
Thank you very much, and congratulations for the presentation. Are there questions for the audience?
Yes,
Professor
John?
Marini?
Very nice presentation. Can you compare this technique with tracheal gas insufflation, a technique that 20 years ago or more, 30 years ago, was causing some excitement because we could take away the dead space of the central airway and the apparatus by a gentle flow during expiration. Could you elaborate a little bit on what are the differences?
Basically, I'm not familiar, perhaps with this older technology, perhaps because that was, like you said, an orphan technology used and then abandoned 20 years ago. This technology, it basically completely supports expiration. So the expiration is completely controlled. And I would say that this is the main difference. So yes, indeed, you can decrease the amount of dead space, and that can probably explain why the gas exchange is improved. Yes. So not only probably due to improved tidal volume distribution, but also via decreased dead space. That's true.
I think that orphan technology is actually something that of value that could be, with modern perfection techniques, improve things a little bit over and above what we did back then and 25 years ago.
Absolutely.
Yes, question here.
Thank you for your presentation, and as I understand that this mainly was used in a narrow tube, using narrow tube to have upper airway surgery, but basically in that situation lung is normal lung, and when we are treating a abnormal like ERDS, can this methodology will be applicable?
Yes, as you could probably see during my presentation, there was also a preliminary study in ARDS patients, and that was also easy to use, provided you have enough nurses, and it provides adequate gas exchange.
Konstantin, it seems the limitation now is that the device itself has been designed for short-term use during specific surgery, and in terms of safety and feasibility, it's not ready yet for more complicated patients.
Not for the ICU, for sure, because it's designed based on this Venturi's valve. It precludes application of any other modes. If they are able to combine it with a conventional ventilator as an add-up, then you can have probably some kind of backup mode, and that would be way more useful, I think.
Thank you. Thank you very much.
Well, thank you, everybody. That was a great session, a lot of physiology and clinical applications, so thank you all.